Okay, everyone, let's just take a moment together. Go ahead and inhale deeply, hold it for a second, and now exhale slowly. Good. Now, just take a moment to reflect on one part of your own journey, maybe as a learner or, in your profession, or even just as someone curious about the world. What's something you're proud of? Taking that moment, well, gratitude actually helps strengthen memory, improve focus, and it really primes the brain for growth. And that focus is exactly what we need today because we're about showing up and staying grounded while we tackle some of the most serious infections you'll likely face in practice. And hey, if this deep dive helps you learn better, please take just a second to subscribe and maybe share it. It really does help grow this community of thoughtful learners, and it helps us keep bringing these high-yield deep dive to more future-ready pharmacists. All right, let's unpack this. Today, we're doing a deep dive into invasive fungal infections, high-stakes diagnosis and treatment. This is part of our NAPLEX infectious disease series, and honestly, it's crucial stuff. Whether you're deep in exam prep or just looking to sharpen your clinical practice, our mission today to help you get a quick but really thorough handle on these complex infections. By the end of this, you should be able to recognize the big players, Candida, Aspergillus, Cryptococcus. You'll feel more confident selecting the right antifungal therapy, both empiric and targeted. We'll also compare the drugs, azoles, Echinocandins, amphotericin, looking at their profiles, their toxicities. And we'll cover host risk factors, diagnostics like 1-villa-3, beta-D-glucan, key monitoring parameters, basically everything to make you feel more prepared for those tough NAPLEX questions and for making those real-world treatment decisions. And just so you know, we're drawing heavily from McGraw-Hill's NAPLEX Review Guide, the 5th edition, specifically Chapter 29.
Yeah, and it's really hard to overstate how significant these infections are clinically. Invasive fungal infections, they come with really high rates of morbidity and mortality. We see this especially in patients who are immunocompromised or critically ill. And what's fascinating and a bit counterintuitive is how our own medical advancements, things like organ transplants, stem cell transplants, potent chemotherapy, even just the widespread use of IV catheters and broad-spectrum antibiotics have actually contributed to them becoming more common.
Wow, yeah. So our tools to help patients are also creating new vulnerabilities.
Exactly. It really poses this ongoing challenge. How do we stay ahead? How do we manage these really difficult pathogens effectively in this, constantly changing medical landscape?
That's a really critical point. So given they're becoming more common, what's the absolute first thing we need to grasp about fungi themselves, like the basic biology difference?
Great place to start. Fundamentally, fungi are eukaryotes. So different from bacteria, right? And for our purposes clinically, we mostly think about them in two main forms, yeasts and molds.
Okay, yeasts and molds.
But there's also this really interesting group called dimorphic fungi. These guys can actually switch forms. They might be a mold out in the environment, but then inside the human body, at body temperature, they act like a parasitic yeast.
Shapeshifters, basically.
Pretty much. Think of things like blastomyces dermatitis, histoplasma capsulatum, coccidioides immatus. We often call these endemic fungi because you usually get exposed to them in specific geographic areas.
Got it. Yeasts, molds, and the dimorphics. So when we talk about the ones that most often cause invasive infections in people, where do we start? Which group is the biggest problem?
Hands down, you start with Candida species. They are by far the most common cause of invasive fungal infections. Now, when we say Candida, C. albicans is the classic one, but you absolutely have to know the non-albican species too, like C. glabrata, C. pyropsilosis, C. tropicalis. They behave differently sometimes.
Okay, so Candida's number one, but aren't they normally around?
Exactly. That's the key point. They're normal inhabitants of our gut, our skin, the female genital tract. They live on our mucous membranes. The danger comes when the host's defenses are down, or maybe after broad-spectrum antibiotics wipe out competing bacteria, allowing Candida to overgrow and then, crucially, move into normally sterile places like the bloodstream.
Ah, so that's how we get things like candidemia.
Precisely. Candida in the bloodstream, or invasive candidiasis, where it infects organs like the liver, spleen, or causes peritonitis. It's an opportunistic takeover.
Makes sense. So what kind of patient or what clinical situation should immediately make us think high risk for invasive candidiasis?
Excellent question, because identifying risk is key for early suspicion. Top of the list, neutropenia, low white blood cell count. Then diabetes, any significant immunodeficiency, patients on high-dose steroids or other immunosuppressants, chemotherapy.
Okay.
Also patients on TPN, total parenteral nutrition. And as we mentioned, prior broad-spectrum antibiotic use is a huge one. Recent major surgery or extensive burns also significantly raise the risk.
That's a lot of common scenarios in hospitalized patients.
It is. And beyond Candida, there's another yeast worth knowing well, Cryptococcus neoformans. It's famous for its capsule. You usually find it in soil or associated with bird droppings. It's less common than Candida, but it's notorious for causing meningitis, especially in immunocompromised patients, like those with advanced HIV.
But only in immunocompromised patients.
Mostly, but not exclusively. That's a key pearl. Don't rule it out completely in someone without obvious immune issues. It can still happen.
Good point. Okay, so yeasts are the big players. What about molds? Are they in the same category of risk, or do they pick on different people?
Molds are definitely a different beast. They cause fewer infections overall than yeasts, but when they do strike, it's typically in patients with really, really suppressed immune systems. Think profound neutropenia, or maybe post-transplant patients on heavy immunosuppression. The most common molds we worry about clinically are Aspergillus species, A. fumigatus, A. flavus, A. niger. Aspergillus is everywhere. Soil, water, decaying plants. We actually breathe in the spores all the time.
So why don't we all get sick?
Our immune system usually handles it just fine. The problem arises when those defenses fail. That's when you can get invasive aspergillosis, and honestly, the mortality rate with that is tragically high.
Wow.
And then there are the mucorales, sometimes called zygomycetes. These fungi can cause incredibly destructive infections, like rhino-orbital cerebral mucormycosis. And the really grim part, our treatment options against them are very limited. It makes getting the diagnosis right and fast absolutely critical.
Okay, so knowing these fungi can be hard to find, especially in really sick patients. How do clinicians actually track them down? What's the diagnostic game plan?
Yeah, that really is the million-dollar question, isn't it? The absolute first step is just having a high index of suspicion. You have to think fungal infection, especially in those at-risk patients showing signs of infection that just aren't getting better, despite good broad-spectrum antibacterial coverage.
So if the antibiotics aren't working, think fungus.
Exactly. Once you suspect it, then you bring out the diagnostic tools.
What does that toolkit look like?
Well, cultures are definitely a starting point. You can grow organisms like Candida and Cryptococcus from blood, cerebrospinal fluid, tissue biopsies, you name it. But here's the kicker compared to bacteria. Fungi usually take a lot longer to grow in the lab.
Which means delays in targeted treatment.
Right. Precious time lost. So we can't rely only on cultures. We use specific stains and assays too. Like India ink is a simple, quick stain used on CSF to look for the capsule of Cryptococcus neoformans under the microscope. Then you have antigen assays. These detect specific fungal components. Histoplasma antigen test, for example, or the galactomannan antigen assay, which is pretty specific for aspergillosis. These can give you results much faster than culture.
What about imaging?
Very important, especially for molds and those endemic fungi. CT scans, computed tomography, give you a much better look than standard x-rays. For invasive pulmonary aspergillosis, there were some classic CT findings. Clinicians look for the halo sign early on, or maybe the crescent sign later. These can be really suggestive.
Halo and crescent signs. Oh, okay.
And finally, we have biomarkers. The big one is the 1,3-D-glucan test, often called the Fungitel test. Beta-D-glucan is a component of many fungal cell walls, so this test can be a really helpful, though nonspecific, early indicator that some kind of invasive fungal infection might be present, sometimes even before cultures flag positive. It helps point you in the right direction.
So a combination of suspicion, cultures, specific tests, imaging, and biomarkers. Quite the detective work.
It really is.
Okay, so we suspect it, we run the tests, hopefully we get a diagnosis. Now we need to treat. Given how serious these infections are, is prevention a major strategy, or is it mostly about hitting it hard once infection develops?
Oh, prevention prophylaxis is absolutely critical, but only in specific, very high-risk groups. We don't give antifungals to everyone.
Right, so who gets prophylaxis?
We routinely use it for patients undergoing hematopoietic stem cell transplants, certain high-risk leukemia patients during induction chemo, and often in liver and lung transplant recipients.
And what drugs do you use for that?
Typically oral or IV azole antifungals. Fluconazole is common, or sometimes posaconazole, depending on what you're trying to prevent.
Yeah.
That's primary prevention. There's also secondary prophylaxis, or suppression, like for cryptococcal disease in HIV patients. They'll stay on daily oral fluconazole until their immune system recovers substantially, specifically a CD4 count over 100 for at least 6 months.
Got it. So prophylaxis for the highest risk. But for active infections, what's the general game plan? It sounds like it needs to be tailored.
Highly tailored. Your choice of antifungal really depends on, well, several things. What fungus do you think it is? Or know it is? Yeast or mold? How sick is the patient right now? And what's their underlying immune status?
Okay.
Then you have to layer on other factors. You need susceptibility data if you have it. You have to watch the QTC interval on the EKG. You absolutely have to consider potential drug interactions, and antifungals have tons of interactions. And, of course, the side effect profiles of the drugs themselves.
Sounds like where pharmacists really shine.
Absolutely essential. Because these treatments are often long, toxicities and interactions become major management issues. And frankly, in many critically ill patients, think persistent fever, central lines, dialysis, neutropenia. Already on broad antibiotics, you'll actually start empiric therapy for invasive candidiasis before you even have definitive proof. You can't afford to wait.
You treat based on high suspicion.
Exactly. And then how do you know it's working? You look for the fever to resolve and ideally for follow-up cultures to become negative to sterilize. That's your signal you're on the right track.
Okay, that lays out the strategy nicely. Now let's dig into the actual drugs, the antifungal arsenal. These are powerful medicines, but they all seem to have their own quirks and challenges. Let's start with the oldest class, the polyunes, specifically amphotericin B.
Amphotericin B. Clinicians often have a love-hate relationship with it, sometimes called amphoterrible because of its side effects.
Amphoterrible, okay.
Yeah. But despite that, it's incredibly effective. Its mechanism is pretty straightforward. It binds to ergosterol, which is a key lipid in the fungal cell membrane, but not human cells. This binding creates pores or channels in the membrane, making it leaky and is essentially killing the fungal cell. It's fungicidal, it kills fungi, and it has a really broad spectrum against both yeasts and molds.
So it hits almost everything.
Pretty much. Historically, it really was the gold standard.
Oh.
Its use has definitely decreased a bit with newer, less toxic agents available, but it absolutely still has a crucial role, especially for severe infections or when other drugs won't work or aren't appropriate.
So if there's one thing listeners absolutely must remember about Ampho B's toxicity, what is it?
Nephrotoxicity. Kidney damage. That is the single biggest dose-limiting toxicity for all formulations of amphotericin B. You have to monitor kidney function relentlessly.
Are the newer versions better with that, the lipid ones?
Yes, the lipid-based formulations, there's liposomal amphotericin B, brand name Ambisome, and amphotericin B lipid complex, Abelset. They are significantly less nephrotoxic than the original conventional deoxycholate formulation. They still can cause kidney injury, especially with other nephrotoxic drugs, but it's generally less severe and less frequent. Managing kidney function is paramount when using any form of Ampho B.
Okay, kidney function number one. What about those infusion reactions everyone talks about? Fever, chills?
Yeah, very common. Fever, chills, rigors shaking chills. Premedication is standard practice, usually acetaminophen and diphenhydramine before the infusion. Another key clinical pearl, especially for mitigating nephrotoxicity, is giving saline boluses like 500 to 1,000 milliliters of normal saline before and sometimes after the infusion. It seems to help protect the kidneys.
Good tip.
And the liposomal formulation, Ambisome, tends to cause fewer of these infusion reactions compared to the others. Also watch electrolytes. Ampho B is notorious for causing potassium and magnesium wasting. You have to monitor levels closely and replace aggressively.
And cost, are the lipid ones way more expensive?
Oh yeah, considerably more expensive. And interestingly, while they have a much better toxicity profile, they haven't consistently shown better survival rates compared to the conventional form when dosed appropriately.
Yeah.
So it's often a trade-off between toxicity and cost. And remember, dosing is different. Lipid forms are dosed higher, like 3 to 5 millibig kilograms versus 1.5 milligig kilograms for conventional. Also, lipid forms often need a special 5-micron filter during administration.
Lots to keep track of with Ampho B. Okay, next up, flucytosine, or 5-FC. What's the story here? It sounds different.
It is different. Flucytosine is a pyrimidine analog. It gets into the fungal cell and gets converted into 5-fluorouracil, or 5-FU, which you might know as a chemotherapy agent. This 5-FU then messes up fungal RNA and protein synthesis.
So it works inside the cell. What's the main catch with using it?
The absolute crucial caveat.
Yeah.
You never use flucytosine alone as monotherapy. Fungi develop resistance to it incredibly quickly if you do. Its main role, really its only major role nowadays, is in combination with amphotericin B. Specifically, for the initial 2 weeks of treatment, the induction phase for cryptococcal meningitis, they work synergistically.
Combination only. Got it. How's it given?
It's an oral capsule, has pretty good absorption, gets into the cerebrospinal fluid really well, which is great for meningitis, and it's mainly eliminated by the kidneys, so dose adjustments for renal dysfunction are absolutely essential.
And its big toxicity concern.
Bone marrow suppression. That's its black box warning. It can cause neutropenia, thrombocytopenia, anemia, Basically, low blood counts across the board. We have to monitor blood counts very closely. GI side effects are also pretty common.
Okay, so potent, combination only, watch the blood counts, adjust for kidneys. Now, the azoles, this feels like a big, complicated family of drugs. Before we get into specifics, are there any general family traits we should know, things they mostly have in common?
Absolutely. That's a great way to think about them as a family with shared characteristics. Their main mechanism is inhibiting a fungal enzyme called 14-methylase. This enzyme is crucial for making ergosterol, that key component of the fungal cell membrane we talked about with ampho-B. So azoles disrupt membrane integrity, but in a different way.
Okay, different mechanism targeting ergosterol synthesis.
Right. On the downside, resistance can definitely develop, especially with long-term use. And the biggest family headache, drug interactions. They are notorious inhibitors of the cytochrome P450 enzyme system, especially CYP3A4. This means they can significantly increase the levels of many other drugs the patient might be taking. Managing these interactions is a huge part of using azoles safely.
Okay, drug interactions are a major flag. Anything else?
Hepatotoxicity, liver injury can happen occasionally, so you need to monitor liver function tests. And most azoles have the potential to prolong the QTc interval on the EKG, which raises concerns about cardiac arrhythmias. There is one important exception, though.
Which one?
Isavuconazole. It's the odd one out. It actually tends to shorten the QTc interval, a very unique feature.
Interesting. Okay, let's tackle them individually. Fluconazole, D-glucan. You called it the workhorse earlier.
It really is. Fluconazole is probably the most commonly used triazole. It's a go-to for many types of candidiasis. It's crucial for treating cryptococcal meningitis, and it's used for prophylaxis, especially in stem cell transplant patients.
Why is it so popular?
It's generally well tolerated, comes in both IV and oral forms with excellent oral bioavailability, and it has fewer drug interactions compared to some other azoles, although it can still interact with drugs like warfarin, increasing its concentration. Its excellent penetration into the CSF is a massive advantage for treating meningitis. It's cleared by the kidneys, so again, dose adjustments are critical if kidney function is impaired.
What about what it doesn't cover? Its spectrum limits.
That's key. It works well against Cryptococcus and most Candida species, C. albicans, C. parapsilosis, C. tropicalis. However, it has absolutely no activity against molds like Aspergillus. And it doesn't cover Candida crusei. And here's a really important nuance for Candida glabrata. Fluconazole is often listed as susceptible dose-dependent, or SDD.
What does SDD mean practically?
It means standard doses might not be enough. You often need significantly higher doses of fluconazole to effectively treat C. glabrata, assuming it's SDD and not outright resistant. Just seeing susceptible isn't the whole story. You need to know the MIC and potentially use higher dosing. And remember, for cryptococcal meningitis, after the initial ampho-B plus flucytosine induction, patients usually switch to fluconazole alone for the longer consolidation and maintenance phases.
Okay, so fluconazole. Great for many Candida and crypto. Good CSF penetration, watch the kidneys, but no mold activity, and be careful with C. glabrata dosing. What about itraconazole, Sparanox?
Itraconazole has a broader spectrum than fluconazole. It does cover Candida species and also has activity against some molds, including Aspergillus. However, its use nowadays is somewhat limited, mainly because its pharmacokinetics, especially oral absorption, are really unpredictable.
Unpredictable absorption. How so?
Yeah, the capsule form needs food and an acidic environment in the stomach to be absorbed well. Some people even recommend taking it with a cola drink. Acid-suppressing drugs like PPIs or HU blockers can drastically reduce its absorption. There's also an oral solution that gets absorbed better. But, and this is critical, the capsules in the solution are not interchangeable dose for dose because their bioavailability is so different.
Wow, that sounds tricky to manage.
It can be. Itraconazole also has a black box warning about potential negative inotropic effects, meaning it can weaken heart muscle contraction. So you have to use it with extreme caution in patients with heart failure or ventricular dysfunction. Because of the absorption variability, monitoring trough serum drug levels is often recommended to make sure you're actually achieving therapeutic concentrations. It's mostly used for endemic fungal infections like blastomycosis or histoplasmosis now.
Okay, itraconazole. Broader spectrum, including some molds, but tricky absorption, heart failure warning, often needs TDM. Now, voriconazole, VFNND, you said it's first line for aspergillosis. This one sounds like it comes with baggage too.
It does. Voriconazole is a really important drug. It's an analog of fluconazole, but with significantly broader activity against Candida, including some fluconazole-resistant strains, and importantly, excellent activity against Aspergillus. That's why it's considered first-line therapy for invasive aspergillosis.
What's the baggage?
It's pharmacokinetically very complex. It has numerous drug interactions, way more than fluconazole. It exhibits nonlinear pharmacokinetics, meaning if you double the dose, you might get much more than double the drug level, which makes dosing tricky. And its metabolism is heavily influenced by genetic variations in the CYP2C19 enzyme.
Genetic variation, so people metabolize it differently.
Exactly. Some people, particularly a percentage of Caucasians and Asians, are poor metabolizers. They break down the drug very slowly, leading to potentially toxic high levels on standard doses. Conversely, ultra-rapid metabolizers might clear it too quickly, leading to treatment failure.
So how do you handle that variability?
Therapeutic drug monitoring, TDM, measuring drug levels in the blood, becomes really crucial for voriconazole. It helps you ensure the patient is in the therapeutic range, effective but not toxic.
Okay, TDM is key. What about side effects specific to voriconazole?
The most characteristic side effect is reversible visual disturbances. Patients might experience blurred vision, changes in light perception, color vision changes, photophobia. It's usually temporary, but patients need to be warned about it, especially regarding tasks like driving.
Visual changes, okay. Any formulation issues?
Yes. It comes in oral and IV forms, but the IV formulation contains a solubilizing agent called cyclodextrin. This cyclodextrin carrier can accumulate in patients with kidney problems and worsen renal failure. So the recommendation is generally to avoid the IV formulation if the patient's creatinine clearance is less than 50 millioles per minute, at least after the initial loading doses. Dose adjustments are also needed for liver dysfunction.
Voriconazole, great for Aspergillus, but complex PK, needs TDM, visual side effects, and IV cyclodextrin issue in kidney disease.
Got it.
What about posaconazole, Knoxville?
Posaconazole is another broad-spectrum azole. It's approved for prophylaxis against Candida and Aspergillus infections in those high-risk neutropenic patients we talked about earlier, and also for treating oropharyngeal candidiasis.
How's its absorption compared to itraconazole?
The original oral suspension also had variable absorption issues. Similar to itraconazole, it needed to be taken with a high-fat meal, and acid suppressants interfered with it. This led to the development of delayed-release tablets and an IV formulation, which provide much more reliable and consistent drug exposure.
So the newer formulations are better?
Much better, much more predictable. But, like voriconazole, the IV formulation of posaconazole also contains that cyclodextrin carrier, so the same caution applies in patients with significant renal impairment, CRCL50-LL-MAN. And again, because of potential variability, TDM is often used for posaconazole as well, especially when used for treatment rather than just prophylaxis.
Okay, posaconazole, broad spectrum, prophylaxis star, newer formulations, fixed absorption issues, but IV still has cyclodextrin. And finally, the newest azole on the block, isovuconazole, Cresemba. What makes it different?
Isovuconazole is administered as a prodrug, isovuconazonium sulfate, which gets converted to the active drug. It's available both orally and IV. Its spectrum is similar to voriconazole good against Candida and Aspergillus. The big advantages are its pharmacokinetics are much more predictable than voriconazole, meaning less variability between patients.
Less need for TDM then?
Generally, yes, TDM is less commonly required than for voriconazole or posaconazole. And critically, the IV formulation does not contain cyclodextrin. That's a huge plus for patients with kidney disease.
No cyclodextrin, that's good. And you mentioned something about QTC earlier.
Right, that's the other key differentiator. Unlike most other azoles that can prolong the QTC interval, isovuconazole actually tends to shorten it slightly. This makes it a potentially safer option in patients already at risk for QTC prolongation. Plus, it also has activity against some species of Mucorales, the fungi that cause mucormycosis, offering another option for those really tough-to-treat infections.
Isovuconazole, predictable PK, no IV cyclodextrin, shortens QTC, covers Mucorales too. It sounds like a significant advance.
It offers some distinct advantages for sure.
Quick pause here. If you're finding this breakdown helpful, maybe learning something new, please do hit that like or subscribe button. It genuinely helps us out and makes sure other learners like you can discover this deep dive.
All right, last major class, the Echinocandins. These seem to be increasingly popular, especially for Candida. What's their story?
Yes, they've become real frontline agents, especially for candidemia. This class includes caspofungin, mycofungin, anidulafungin, and the newest member, resifungin. Their mechanism is totally different from the azoles or amphotericin.
How do they work? They inhibit an enzyme called 1,3-glucan synthase. This enzyme is essential for building the fungal cell wall, specifically the glucan component. Since human cells don't have cell walls, let alone this enzyme. The echinocandins are very specific to fungi.
Nice targeted mechanism. What's their spectrum like?
Excellent activity against most Candida species, including those that might be resistant to fluconazole, like C. glabrata and C. cruce. They also have activity against Aspergillus species, though they're usually used in combination therapy for aspergillosis, not typically as monotherapy.
And side effects, interactions.
This is where they really shine. Echinocandins are generally very well tolerated. They have minimal side effects compared to amphotericin or even some azoles, and crucially, they have very few significant drug interactions because they aren't heavily metabolized by the CYP450 system.
That's a huge advantage. Any downsides?
The main limitation is they are only available as IV formulations. There's no oral echinocandin. Also, they don't penetrate particularly well into the CSF or the urine, so they're not ideal choices for CNS infections or fungal UTIs.
Yeah.
But a plus is they don't require dose adjustments for renal insufficiency.
IV only, well-tolerated, few interactions. What about risofungin, the new one?
Risofungin, Rezio, is exciting because it's a long-acting echinocandin. It's given once a week intravenously. This is a potential game changer for treating candidemia and invasive candidiasis, as it could facilitate outpatient IV therapy or allow for earlier hospital discharge compared to drugs needing daily infusions.
Once weekly. Yeah, that could make a big difference. You mentioned therapeutic drug monitoring, TDM, a few times, especially for the azoles. Can you just circle back and emphasize why that's so important?
Absolutely. TDM is really a cornerstone for safely and effectively using certain antifungals, particularly voriconazole, itraconazole, and posaconazole. Why? Because as we discussed, these drugs can have really variable pharmacokinetics, things like inconsistent oral absorption, the potential for numerous drug interactions altering their levels, and those genetic differences in how people metabolize them.
So TDM helps manage that variability.
Exactly. By measuring the drug concentration in the patient's blood, usually a trough level, right before the next dose, you can ensure they're within the target therapeutic window. You want levels high enough to kill the fungus, but not so high that you cause toxicity. For serious life-threatening infections, getting the dose right is critical. Underdosing means treatment failure. Overdosing means potentially serious side effects. TDM helps you navigate that tightrope.
Makes perfect sense. Okay, we've covered the bugs and the drugs in detail. Let's try to pull this together with some real-world scenarios. Picture this. You have a patient with neutropenic fever. They're already on strong, broad-spectrum antibiotics, but the fever just isn't breaking. What's the thought process?
Yeah, that's a classic high-stakes scenario. If that fever persists despite good antibacterial coverage in a neutropenic patient, your alarm bells for an invasive fungal infection should be ringing loudly. You have to act.
What action?
Empiric antifungal therapy. You need to start an agent that covers the most likely culprits in this setting, which are primarily Candida species and Aspergillus. So your choices would typically be a broad-spectrum agent like amphotericin B, especially a lipid formulation, or potentially voriconazole, isovuconazole, or an echinocandin like cascofungin or mycofungin. The specific choice might depend on local resistance patterns, the patient's other conditions, potential drug interactions, etc. But you start empiric coverage.
Okay, scenario 2. A patient who received an organ transplant starts developing new nodules in their lungs on a CT scan. Red flags. Plan.
Huge red flag. In a transplant recipient on immunosuppression, new pulmonary nodules immediately make you think Aspergillus until proven otherwise. They are highly susceptible.
So what do you do?
You move fast on diagnostics. Definitely get a serum galactomannan antigen test, maybe a beta-D-glucan. You look closely at that CT scan for those suggestive signs. The halo or crescent sign. Bronchoscopy with lavage and maybe biopsy might be needed. In treatment, if Aspergillus is highly suspected or confirmed, would typically be initiated immediately with voriconazole as the first-line agent, or possibly liposomal amphotericin B. Early aggressive treatment is key for survival in invasive aspergillosis.
Okay, last one. You have a patient with confirmed candidemia, Candida in the blood. They were started empirically on an echinocandin, say mycofungin. Now you get the species ID back and steptabilities. When might you consider stepping down to fluconazole?
Great question, because step-down therapy is really important. Echinocandins are excellent initial choices for candidemia, especially in sicker patients or before you know the species. But once you have the ID and susceptibilities, you reassess.
What's the key factor for stepping down to fluconazole?
The species and its susceptibility. If the species is Candida albicans and it's susceptible to fluconazole, which most albicans are, then stepping down to oral fluconazole once the patient is stable and improving is often the preferred strategy. Fluconazole is available orally, It's less expensive, and it allows for easier transition to outpatient therapy to complete the treatment course.
But what if it's not albicans?
Right. If it comes back as Candida glabrata or Candida krusei, which are often resistant or less susceptible to fluconazole, then stepping down to flutonazole is usually not an option. You'd likely continue the echinocandin or potentially switch to another agent like voriconazole depending on susceptibilities. Knowing the species and its susceptibility profile is absolutely critical for that step-down decision.
Those scenarios definitely illustrate the complex decision-making. Any other specific patient groups or special situations we need to quickly mention?
Yeah, just briefly, pediatrics antifungal use is common in children, including neonates. For neonatal candidiasis, amphotericin B, fluconazole, and the echinocandins are all used, with specific dosing considerations.
And pregnancy.
Pregnancy is always a careful risk-benefit discussion. Amphotericin B is generally considered the safest option, being pregnancy category B. Most of the azoles, echinocandins, and flucytosine are category C, meaning potential risks can't be ruled out. Yeah. Voriconazole is category D, indicating evidence of potential fetal risk, so it's generally avoided if possible. It really requires careful consultation and weighing the mother's need for treatment against potential risks to the fetus.
Okay, so wrapping this all up, what's the big picture takeaway for us as pharmacists and healthcare professionals dealing with these infections?
I think the big picture is that while invasive fungal infections are serious, potentially devastating threats, we do have increasingly sophisticated tools to diagnose and manage them. But it requires more than just memorizing drug names. It requires a really deep understanding of the different fungal pathogens, knowing the nuances of our diagnostic tests, and truly mastering the pharmacology of the antifungal agents, their mechanisms, spectrums, toxicities, and especially those complex interactions. It's about putting all those pieces together for the individual patient in front of you. Making those high-stakes decisions often relies on understanding those subtle differences between, say, Ampho-B's broad power versus an echinocandin's targeted safety profile, or navigating the tricky PK and interactions of the azoles.
That constant vigilance and deep knowledge seems key, which leads to a final thought. As our medical technology keeps advancing, as we get better at keeping very complex immunocompromised patients alive longer, what's next? What new fungal threats or resistance patterns might emerge? And how will our antifungal toolkit need to evolve to keep pace, to stay not just one step, but maybe several steps ahead? Something definitely to think about. Well, thanks for joining me on this deep dive today. Invasive fungal infections, they demand urgency, they demand accuracy, and definitely confidence. Hopefully, you now feel you have more of the knowledge needed to back that up. If this session helped you feel more prepared, whether it's for the NAPLEX or for your day-to-day clinical practice, please do consider liking, subscribing, or maybe sharing this with classmates or colleagues. We're really trying to build a community here of sharp, humble, and practice-ready pharmacists. Until next time, keep learning, stay grounded, and take good care.